Good evening, everybody. Hope you all are doing well. Welcome to my general surgery live study session. So, basically, in this study session, I'm going to prepare for my general surgery examination, and the approach of the session is essentially just to basically grasp common presentations that patients present with in surgery, as well as a medical doctor. What is our approach as an internship in terms of the causes of whatever the patient is experiencing? What are the possible diagnosis of what the patient is experiencing? What workup is essential as the initial management, as well as um, basically surgical management, complications of the condition, as well as complications of surgery. So I'm just going to share my screen. I think I'll do. Okay. Okay, so the first condition that patients generally present with is that of abdominal pain. Now, looking at the abdomen, our approach to abdominal pain is that um, there are many causes of abdominal pain, right? And we can basically differentiate it into gastrointestinal causes, genitourinary causes, gynecological causes in females, vascular causes, infectious causes, then other miscellaneous causes, and then lastly we'll speak about certain malignancies which causes this abdominal pain, and last but not least, just to exclude some functional disorders, right, which could cause this abdominal pain. So one of the most common causes of abdominal pain is that of pain in the right iliac fossa. Now, as you can see in the right iliac fossa, it is where the appendix is located. And the most common condition is that of appendicitis, and typically presents with right lower quadrant pain. It usually starts in the center of the umbilical region, and therefore it also migrates much further down as well. And appendicitis is mostly associated with nausea and vomiting. So I'm going to go to the chapter in my book of acute appendicitis, just to understand acute appendicitis. I've actually done a case scenario on acute appendicitis. So this kind of brings me just to open up more of a discussion of acute appendicitis. So essentially, appendicitis, okay. So appendicitis is essentially when there's inflammation in the appendix. So in terms of the anatomy, it is in the lower quadrant. It is in the right lower quadrant, and it's usually in the posterior medial wall of the cecum. It's usually about 5 to 10 centimeters long. It has different layers. It has your mucosa, your submucosa, the muscularis externa, as well as the serosa. The mucosa is similar to the large intestine, but the submucosa contains lymphoid tissue, which is more prominent in younger individuals. The blood supply to the appendix is that of the appendicular artery, which is a branch of the ileocolic artery, which supplies the appendix. And in the venous drainage is through the appendicular vein into the superior mesenteric vein. Now, the nerve supply, the appendix receives autonomic innervation from the superior mesenteric plexus, with sympathetic fibers originating from the 10 spinal nerves and parasympathetic fibers from the vagus nerve. The lymphatic drainage, the appendix is very rich in lymphoid tissue, which drains primarily into the ileocholic lymph nodes. The appendix plays a huge role in immune function, a reservoir for gut bacteria. One of the main causes for appendicitis, the main cause is obstruction. So there's either obstruction via a fecalith or an enlarged lymphoid follicle, tumor, or a foreign body. Certain infections can also cause appendicitis in the gastrointestinal region. Genetic factors can also play a role in enhancing your chances of getting appendicitis, as well as certain dietary factors, which can make you stool hard, and there's a very low fiber diet, which can increase the risk of you actually developing a fecalith, which can cause that obstruction. Risk factors include age, so it's most commonly among individuals between the ages of 10 and 30 years old. The risk does decrease with age in older adults. Males are more likely to develop appendicitis than females. Family history puts you at risk of appendicitis. A diet very low in fiber and rich in processed foods can also contribute as well. GI infections, spoke about the obstruction from fecalith of foreign bodies or tumors. Certain medical conditions such as cystic fibrosis, inflammatory bowel disease, and other GI disorders. Environmental factors, exposure to pathogens, previous surgery, and immune system factors. So, in terms of the pathogenesis or how appendicitis comes about, is that there is definitely an obstruction by the actual fecalith. This increase in pressure, then you get bacterial proliferation. It's this obstruction or this creates a kind of a house which is very good for the bacteria to actually grow, while good for them, bad for us. And there is this inflammatory response which the body now kind of enhances. Over time, it leads to tissue ischemia and necrosis. So, because of the obstructions, or it could be an obstruction, inflammation is in your particular artery, which leads to a reduced blood flow, and that can lead to ischemia and therefore infarction. What can actually happen is that the walls can actually get weaker, thinner and thinner, and that walls of the appendix can actually burst. And that pus can create peritonitis in the abdomen as well. Now, in terms of the clinical features, patients do experience abdominal pain, nausea and vomiting, loss of appetite, fever, as well as diarrhea and constipation. In terms on physical examination, patients will have tenderness in the right lower quadrant. There could be rebound tenderness, guarding, and rigidity. There could be a psoas sign. Now, a psoas sign is pain upon extension of the right upper hip, suggesting a retrocecal appendicitis. Then you get something called an obturator sign. The sign is essentially which is pain upon internal rotation of the right hip, indicating possible appendiceal irritation. Now, what is the differential diagnosis of acute appendicitis? So, a patient presents with the right lower quadrant pain, and obviously, there's much other causes of right lower quadrant pain. So, we're still on this topic of the patient comes into the emergency center with right lower quadrant pain. On the top of our differential list, we are thinking of appendicitis. This is just abdominal pain, right? But if it's more specific to the right lower quadrant, yes, we do think of appendicitis, but there's so much other things that should go into our list. Because we're busy with at the intestines, so in both males and females, just a general approach, you can get something called it could possibly be a diverticulitis, which is inflammation in the pouches of your inflammation in the diverticulum. You can get the ileitis or Crohn's disease, that's inflammation in the bowel. Intestinal obstruction can also cause this pain. There could be something called a mesenteric adenitis. um, which is inflammation of the lymph nodes in the mesentery. You can get a perforated peptic ulcer, which a peptic ulcer which perforates, causing that abdominal pain, or perhaps inflammation in the colon, known as a colitis. In females, an ovarian cyst, ovarian torsion can cause right lower quadrant pain, and ectopic pregnancy, pelvic inflammatory disease, as well as endometriosis. Now, some urinary causes in adults include a UTI as well as renal colic. So, looking at the anatomy of the body, the the kidneys is there as well. So it could be a renal colic or a UTI. Obviously, with renal colic, there will be hematuria and flank pain. UTI, there will be associated dysuria, okay, pain on urination. Now, in children, you should think of gastroenteritis, intussusception, testicular distortion, and pneumonia. In older adults, you also need to think now more of perhaps a bowel obstruction, aortic aneurysm, which can be seen with abdominal pain, or even malignancies, especially in older. So your age plays a huge role in also determining which differential diagnosis is more on top of the list than others. Um, in terms of the investigations, now acute appendicitis is um, a clinical diagnosis with history of symptoms of the right lower quadrant pain, nausea, vomiting, anorexia, fever, and an opposite physical examination. Now, McBurney's point tenderness is basically two-thirds, closer to about two-thirds the agony from the umbilicus. Okay, we spoke about all that clinical signs. You would want to do a FBC, and it should it would show an increase in the white cell count because of this inflammation. CRP would also be high because of this inflammation. Okay, so that's that, and then you would also want to take a urinary to rule out any urinary tract infection or renal pathology as well. So basically, a simple dipsticks, right? In terms of the imaging, ultrasound is commonly used, mostly in children and a pregnant woman. So ultrasound would be the first line investigation, and then the CT scan with contrast would be the gold standard investigation. How would we manage this? So initial assessment is very important, history exam, and your blood tests. Resuscitation is extremely important in patients who are acutely unwell. Uncomplicated appendicitis, you would want to do a surgical management, such as a laparoscopic appendectomy, which is the gold standard. But sometimes an open appendectomy might be done, but mostly it's a laparoscopic appendectomy. Antibiotic therapy is quite essential, going broad spectrum. The most common antibiotics I've seen in the wards was that of Augmentin. Complicated appendicitis. So now, if there's perforation, the appendix have ruptured. If there's an abscess or peritonitis, so if there's an abscess or phlegm, you should do non-operative management. So you cannot operate. We should give either antibiotics and percutaneous drainage if an abscess is present, and surgery may be delayed after the inflammation has subsided. Now, with perforated appendicitis, it is an oh, that's if it's an abscess. So if it's an abscess, it is non-operative management. You give IV antibiotics and you drain the abscess. If the appendix, if the appendix have bursted, you need to do an open or a laparoscopic appendectomy with intra-abdominal lavage for peritonitis. This is an emergency. Post-operative antibiotics is very important. Broad-spectrum antibiotics, and then post-operative care, obviously management of pain, diet, mobilization, as well as monitoring. Complications of appendicitis. So I already mentioned about the perforation or the rupture, which can cause the peritonitis, abscess formation. You get something called an appendiceal phlegmon, which is basically the same as an abscess. The patient can have sepsis, ileus, which is paralysis of the intestines, fistula formation. So a fistula can essentially form between the appendix and outside in the atmosphere, or even between the intestines themselves, so even other organs such as the bladder. Okay. Then the last thing is portal pylophlebitis. So it's a very rare condition, but it's when infection spreads to the portal vein, leading to thrombosis and liver abscesses. Now, indications for surgery for appendicitis includes you have acute appendicitis, diagnosing it clinically, doing the laparoscopic appendectomy. Complicated appendicitis, we spoke about that, where it becomes perforated with the abscess, you need the drainage. Recurrent appendicitis, failed medical management, you need to go for surgery. Okay. Complications of the surgery of an appendectomy essentially includes infection, wound infection, intra-abdominal abscesses, bleeding, anesthesia-related bowel injury, urethral injury. So maybe they cut the urethra, or even a pneumonia. Now, you also get the other delayed complications, including incisional hernia, bowel obstruction, fistula formation, chronic pain, or even a recurrence of the appendicitis. There is a surgical scoring system which is essential with regards to appendicitis, and it's called the Mantel's score. And essentially, the M stands for the migration of pain, where patients score a point of 1, A for anorexia, N for nausea or vomiting, T for tenderness in the right lower quadrant, R for rebound tenderness, E for elevated temperature, R for leukocytosis, increase in the white cell count, and S for shift to the left. Score of 1 to 4 means that there's a low probability that this patient might have acute appendicitis. Score 5 to 6 means that the patient has possible appendicitis, and more investigations are needed, such as an ultrasound or a CT scan. And then score 7 to 10 means that the patient definitely has, much more likely the patient has appendicitis, and surgery needs to be considered. So that's a quick rundown, guys, of appendicitis. So again, speaking around abdominal pain, that was the first on our list of appendicitis. So Aloki spoke about the anatomy. Aloki spoke about the pathogenesis. We already spoke about the presentation, physical examination. So in the physical examination, you get the Rofsing's sign, which is pain in the right iliac fossa with left iliac fossa palpation. Um, you get Banfi sign, which is pain in the right iliac fossa with coughing. Iliopsoas sign, which is pain in the right iliac fossa with hyperextension of the right hip. And the obturator sign, which is pain, is reproducing the lower abdomen with internal external rotation of the right hip. So we already spoke about the dipstick exams, and you can also do a pregnancy test in women, just to rule out that ectopic pregnancy. We already spoke about the full blood count as well as urea and creatinine. We spoke about the scoring system of Manschel's. So M for the migration of pain, A for anorexia, N for nausea, T for tenderness in the oral Q, R for rebound tenderness, E for elevated temperature, L for leukocytosis, and S for shift of white cell count to the left. So we spoke about the abdominal ultrasound, CT, and then lastly you would want to do an MRI just to basically hone down on that particular diagnosis. So the initial management is IV fluids, the broad spectrum antibiotics, as well as the analgesia. Okay, so we spoke about all of that. Then we spoke about the laparoscopic appendectomy as well as the open appendectomy. And then complicated appendicitis is that of the abscess and the appendix mass. Okay. So that's it for the appendicitis. We're now going to move on to the second gastrointestinal cause of abdominal pain in patients. The patient comes to hospital. First thing on our list is appendicitis. What would be the second thing on our list? So, looking at the abdomen. Okay, so looking at the abdomen, we done now with the right iliac, which is the most common one. We're now going to look at the right upper quadrant. Okay, so if we look at the right upper quadrant, so now the patient says, okay, doctor, I have right upper quadrant pain. So if there's right upper quadrant pain, and we hear that it's after a fatty meal, and it could be perhaps his jaundice as well. We're gonna think of a cholecystitis. Now, let me just look at my notes to find where is cholecystitis. Oh, there we go. Okay, so acute cholecystitis. Let's just check. So, let us say that in acute cholecystitis, so one of the main causes of a cholecystitis is that essentially of a gallstone. Okay, so in acute cholecystitis, a gallstone becomes impacted in the cystic duct or Hartmann's pouch, followed by inflammation and eventually infection in the gallbladder wall. So let me just type in cholecystitis. Cholecystitis. Okay, here we go. And inflamed gallbladder. Now, what's essential to understand is that there was a patient that I've seen in hospital that she had a gallbladder, but it wasn't cholecystitis, right? It wasn't inflammation. They thought that it was inflammation, but it was rather the obstruction, right? So instead of a cholecystitis, it was more of a choledochlytitis. Okay, so gallstones usually don't always cause cholecystitis, but the cholecystitis is definitely like when the patient presents with right upper quadrant pain, They may or may not be jaundice, usually after a fatty meal. We're thinking that, okay, this patient could actually have cholecystitis. So essentially, cholecystitis is an inflamed gallbladder. So in acute cholecystitis, the gallbladder becomes impacted in the cystic duct or Hartmann's pouch, followed by inflammation and eventually infection in the gallbladder. The initial symptomatology is similar to biliary colic. And what is biliary colic? Now, biliary colic is the most common clinical presentation of gallstones, and gallstones that impact the cystic duct or Hartmann's pouch initially causes colicky abdominal pain, followed by varying degrees of inflammation in the gallbladder. So this is the cystic duct over here. So if it becomes blocked in the cystic duct, you can have something called biliary colic. Okay. Now, so the initial symptomatology of an acute cholecystitis is essentially similar to biliary colic, right? And patient presents with severe pain in the right upper quadrant, often associated with nausea and vomiting. So it's very similar to the appendicitis, it's just that this pain is in the right upper quadrant. So the natural history of acute cholecystitis varies. They say here that in most patients, the stone will disinfect or pass the early inflammatory process. And wait, in most patients, the stone will disinfect or pass, and the early inflammatory process will resolve. On examination, these patients may be pyrexial and have mild tenderness and guarding in the right upper quadrant. A positive Murphy sign is almost diagnostic of acute cholecystitis. So a Murphy sign is essentially when you put your hand on the abdomen, and essentially when you release, that's when the patient has the pain. I'm just going to confirm Murphy sign. What the Murphy sign indicates possible cholecystitis inflammation of the gallbladder. To test, firmly palpate the right upper quadrant subcostal region, pushing under the ribs, asking the patient to take a deep breath. A positive sign is when significant pain is elicited by this maneuver, usually stopping them mid-breath. So that is essentially Murphy's sign. Okay. Okay. So that is the Murphy sign. If the stone remains impacted, the patient may develop bacterial infection which may progress to impairment of the gallbladder. These patients are severely ill with high spiking fever and rigors and presenting late initial signs of systemic sepsis with hemodynamic instability. Um, and multiple failure and are severely tender on palpation under the right costal margin. Perforation of the gallbladder may be localized if sealed off by the momentum. If the perforation is into the hepatic parenchyma, but with free perforation into the abdominal cavity, causes generalized peritonitis, then acute abdomen and signs of systemic sepsis. Patients presenting with acute cholecystitis are graded to disease severity going to grade 1, grade 2, and grade 3. So it's mild, moderate, severe cholecystitis. Grade 2 cholecystitis is associated with a very high white cell count, a palpable tender mass in the right upper quadrant, duration of complaints more than 3 days, or marked local inflammation, gangrenous cholecystitis, pericholecystic abscess, hepatic abscess, biliary peritonitis, or emphysematous cholecystitis. Grade 3 cholecystitis is cardiovascular, respiratory, renal, hepatic, hematological, and neurological function, dysfunction. So this is acute cholecystitis. So thinking about gallstones as a cause of this pain. So that's acute. That's just a little bit on acute cholecystitis. I think we're going to come back to gallstones. If I'm not 100% sure. Yes, I think we're definitely going to come back to gallstones. I think when we speak about an approach to jaundice. Okay, so we're definitely going to come back to gallstones. But I always would like to find out now, okay, now, if the patient has cholecystitis, what are we going to do? I think I'm going to fetch my other surgical book. So I'm just going to pause this in. Okay, so I'm just looking for the cholecystitis. Um, 412976. Okay, so acute cholecystitis. Essentially, you have severe continuous right upper quadrant pain, often radiates to the right flank and back, associated with anorexia and pyrexia. Tenderness of a gallbladder during inspiration, that's Murphy's sign. Complications of acute cholecystitis includes empyema, which is perforation of an empyema of the gallbladder, abscess by virtue of pus being contained in the gallbladder that is obstructed is rare, indicated by high swelling fever, and severe localized pain. The second complication is that of perforation. So that is essentially with biliary peritonitis, which is very rare and can be a calculus in ICU patients. You can also have something called gallstone ileus. So that is when there's cholecystoenteric fistula formation, which may lead to gallstone entering and obstructing the distal ileum, as you can see in the diagram there. It can basically dislodge and then go through the cystic duct, bile duct, and come and into the intestine, and then basically get stuck, causing ileus. Then you get jaundice. So jaundice is due to compression of the adjacent common bile duct by pressure. This is known as Marizzi syndrome, or by virtue of a gallstone obstructing the common bile duct. Um, you then have biliary colic. So biliary colic as complication is essentially intermittent severe epigastric and right upper quadrant pain, usually associated with nausea and vomiting. It resolves after a few hours. Tenderness of the gallbladder during acute episode is possible. You then have something called chronic cholecystitis. So that's when the patient has repeated episodes of infection, which causes thickening and fibrosis of the gallbladder. Last but not least, you have something called a mucocele, which is a stone essentially in the neck of the gallbladder. Bile is absorbed, but mucus secretion continues, producing a large dense globular mass in the right upper quadrant. If infected, this becomes an empyema. One of the diagnoses and the investigations we're going through as an intern when we see a patient that has right upper quadrant pain, which is a possible acute cholecystitis. We're going to do an FBC, white cell count, UNE for the renal function test, as well as liver function tests, blood culture, and serum amylase in acute presentations. And essentially, that serum amylase is quite essential, essentially to rule out any pancreatitis. Now, we should do it. We should book for an X-ray to exclude ulcer perforation or pneumonia as part of the differential diagnosis. An ultrasound is the investigation of choice to identify stones, determine the wall thickness, and abscess ductal dilation due to a stone within the duct. Um, Early treatment includes IV antibiotics, so co-amoxiclav. Um, okay, so hot emergency cholecystectomy is recommended if the patient's symptoms developed within the preceding 72 hours and imaging confirms the absence of common bowel duct. Okay, just give me 3 minutes, 4 minutes. Okay, but are we gonna hang up, Musna? Okay, yeah, we can hang up. Okay, so see you in 15 minutes, so 11 o'clock. Okay, cheers. Okay, so basically, immersion cholecystectomy is recommended if the patient's symptoms developed within 72 hours, in the presence of hours, And imaging confirms the absence of common bile like stones, and where there is explicit theatre available as a one-stop treatment. Otherwise, the patient has to wait for at least 6 weeks following an episode of acute cholecystitis for an elective cholecystectomy. Now, the definitive surgical treatment is that of a cholecystectomy, which is removal of the entire gallbladder. Now, majority is done laparoscopically, and this is the treatment choice for all patients fit for general anesthesia. And the indications of the surgery is essentially patients with symptoms due to gallbladder stones. So the right upper quadrant pain, positive Murphy sign, nausea, vomiting. Um, Asymptomatic patients with gallbladder stones at the risk of complications such as diabetic patients, history of gallstone pancreatitis, long-term immunosuppressed sickle cell disease. The risk of a laparoscopic cholecystectomy is that of could be converted to an open operation. You can injure injury to the bile duct, as well as bleeding, as well as a bile leak. Now risks increase slightly, but acceptable. It's acceptable in an emergency cholecystectomy. Non-surgical treatments includes the drainage, so the perk drainage of the gallbladder, done under ultrasound or CT guidance. The it's done transhepatic to avoid biliary peritonitis. It's used for empyema of the gallbladder in patients unsuitable for an emergency cholecystectomy. And then the drain needs to stay in for at least 10 days to track to form. After resolution of the infection, the patient may be brought back for an elective cholecystectomy. And yeah, okay. And for patients who are high risk and not suitable for general anesthesia, should have repeated courses of antibiotics with avoidance of fatty foods for prevention of recurrent attacks of cholecystitis. And then ERCP and sphincterotomy for the prevention of further episodes of gallstone pancreatitis. Okay, so that's it, everybody, for the cholecystitis as the second part on the differential for a patient presenting with abdominal pain. Now, patient has epigastric pain radiating to the back. Now, if we go back to our there we go. Back to our image. Now, the patient now has epigastric pain. So the main cause of patients with epigastric pain is that of pancreatitis. Okay, but I think this I'll do in another live. So I'm just gonna take it's been 45 minutes. So I'm going to take a study break now, and we will rejoin again for the next study slot.